Good morning, everyone. I'm Dr. Ashu Agarwal, and I welcome you all to our instruction course, Astigmatism Management at the Time of Cataract Surgery. As part of this course, we have a faculty talk, a keynote address by Dr. SHAIL VASAVADA. So we'll be starting with him, and the course will happen after that. The topic for Dr. SHAIL is Low IOP Phaco, a New Trend. SHAIL, are
Uh,
you ready?
Thank you very much, sir, for letting me speak in your course. So, why do fluidic parameters matter, and do they really impact the eye? So, this was a study we did way back with the gravity fluidics with the Infinity, where we found that when we use higher flow rates and higher bottle heights, it leads to more corneal edema and more anterior segment inflammation on the first post-operative day. And we did live intraoperative IOP transducer measurements, and as you can find that when we use a bottle height of around 100 which was our standard, the intraocular pressure actually rises up to 80 millimeters intraoperatively during our surgery, whereas when we use a lower bottle height of 70-80 centimeters, the IOP remains low and there is less fluctuations, but it's still quite high, up to 50-60 centimeters. With the improvements in fluidics and with the active fluidics, where there is a pressure sensor and a pump rather than a bottle height, you can find that the IOP, not only here in the Infinity, the IOP is not only going up and down, but there are a lot of time taken for recovery, and compared to that with the active fluidics, you'll find that the IOP fluctuations that are occurring are very minimal. So you'll see this graph is fairly stable all through, and whatever peaks and troughs are occurring are recovering much faster than with gravity fluidics. Uh, Thanks to my colleague Dr. Samresh, who helped us to show that this is a cadaver eye where the Berger space is stained with triamcinolone, and just from going from 0 foot position to 1 foot position, look at the amount of trampolining that is occurring, which we never realized during surgery. And then when we raise the bottle height to 110 centimeters and we raise the flow rate to 40, just by going from 0 to 1, 0 to 1, if we go 3 4 times, the pressure fluctuation leads to a rupture in the anterior hyaloid phase, and you see triamcinolone with an intact posterior capsule being seen in the anterior to mid vitreous. So it does impact the amount of parameters that you're using. How do we use fluidics to improve our day-to-day problems? This was a 65-year-old male on oral tamsulosin for benign prostatic hyperplasia, and keep noticing the area of my side port. So I'm using an intraocular pressure of 40. And you'll seeing that the shape of the pupil is slowly but surely becoming more and more oval, with this iris tending to come towards this side port. So typically what we normally find is that once the iris comes, it always keeps coming, and you end up repositing, and you usually end up in a mess. So here I realized that the iris is coming. So what I did was I went to foot position 0. I dropped my IOP from 40 to 30. So I've reduced my intraocular pressure from 40, which was low. I brought it down even further low, and now I went back again in foot position 1. As you can see, the iris has fallen back, and now all through the surgery, I'll be able to maintain this iris in its position without it coming even once to the side port with a relatively lower intraocular pressure. And following that same principle in this eye, which has a relatively even smaller pupil, if you maintain fluidics and with a lower intraocular pressure and low flow rate and stay in the center with your phaco probe, the iris will behave reasonably well all through without it prolapsing to any time. So when in trouble, instead of raising your, so when you are driving a car and there's a trouble, instead of pressing the accelerator, lift up your foot from the accelerator. So whenever in trouble, lower your parameters. In a dense cataract, quite often the posterior leathery plate is very difficult to divide, and therefore we find this technique of multi-level chop, where you occlude with the phaco probe, you come out and occlude at a deeper plane to create and complete the crack, so that there are less chances of, I mean, less lateral separation forces needed. Like in this case, I could not complete the crack in one go. So instead of going too much of lateral separation, I brought out the probe, occluded at a deeper plane, and then completed the crack. Once again, here a very brunescent black leathery plate, as you can see. Come out with your phaco probe, occlude at a deeper plane, and then complete the crack. That will help to reduce the lateral separation forces and therefore less stress on the zonules. But the key is to have very small fragments. So you want to have, there is no fixed number, 4 pieces, 6 pieces, as small as possible. And smaller the fragments, much more easily you will be able to remove them, and you'll be able to remove them comfortably at parameters which we would generally not be using. So here I'm using an intraocular pressure of 20 and a flow rate of 25, and make sure that you don't occlude with your phaco probe. So I bring the fragment to the center, turn my tip sideways, and therefore use the Keros links. If you see, I'm using my left hand to reposition the fragment rather than moving my right hand, because larger fragments, although we sometimes don't realize, we found this on intraoperative OCT, that they keep tumbling and keep hitting the endothelium, and these are the cases which we find that why do I have a striate keratopathy in this case next day when everything intraoperatively seemed to go off well. So with maintaining these principles, you can do quite well. In a post-radial keratotomy eyes, the challenges are quite a few. One is incisions. If possible, you want to try and locate them between two radial keratotomy cuts, but it may not be possible in such eyes where there are a zillion cuts, so you may need a scleral incision, and there's no harm in doing that. But basically, the RK eyes are myopic eyes, and there is a very high chance of low scleral rigidity, that is fluctuating globe, as well as chances of the RK incisions opening up anytime during the cataract surgery. And therefore, in such eyes, using lower parameters definitely helps, because, even with low intraocular pressures, you sometimes find the eyes too deep, or too deep to actually perform the phacoemulsification procedures, and you can achieve such outcomes consistently. However, there will be cases that, in spite of doing everything, like in this case, we had a split in the RK incision. My incision wasn't so scleral, and therefore you have to suture such eyes. Post ICL cataract, two challenges. One is you can do a femtosecond also through the ICL, and it's easy to remove the ICL, but you need a 3.2 millimeter incision, which is too large for our phacoemulsification. And therefore, after removing the ICL, we actually suture the wound on both sides, so that our phaco probe, the main incision, doesn't leak. And these eyes typically are extremely high myope, so very low intraocular pressure generally suffices, like 20 millimeters. And you can follow these principles even in cases of posterior polar with pre-existing defect, protecting the polar until the very end, so that the chamber doesn't fluctuate and there is no split in the capsule. So I think the lower intraocular pressure, if you keep an eye on the intraocular pressure, you'll definitely find that things are improving as far as things are going. How low is low? I don't think there is one fixed number. But I think if we compare gravity fluidics, even if you use an intraocular pressure of 50, that's equivalent to a bottle height of 70. So anything that you use is lower than conventional fluidics. Number is not very important, and our preference is to work between 20 to 50 millimeters of intraocular pressure. Thank you so much once again for the patient listening.
Thank you, Shell, for being part